everyone. Thank you for joining us today. My name is Hannah. I'm the Office Coordinator for the National POLST Paradigm Office. Today our speakers, Angela and Katrina, will be presenting on POLST in the EMS setting. This is our third webinar in the National POLST Paradigm Toolkit webinar series. You can register for the next 3 webinars and also view the preceding webinars at polst.org/toolkit. Our next webinar in the series is POLST in the inpatient hospital setting, and the live session will be next Thursday, May 11th at 1 p.m. Eastern. I'd now like to introduce our presenters today. Angela, paramedic and currently Battalion Chief of Training for Johnson County Med Act in Kansas. Angela also serves as the EMS advisor for the National POLST Paradigm. And Katrina, paramedic and currently the Director for Hospice of Washington County in Iowa. Angela?
Well, thank you for inviting us today. We are happy to share with you a little bit about the toolkit that we have created regarding POLST in the EMS setting. The chapter was designed to give EMS professionals a roadmap to implementation with the knowledge that it really can't be accomplished by EMS alone. Instead, EMS will be working toward community implementation involving primary care, hospitals, long-term care, and hospice. When we talk about POLST and the EMS professional, we may mean those who are responding to a 911 call involving a patient that has a POLST. It may also mean those involved in non-emergent transfers of patients with POLST forms who are being moved among hospital, skilled nursing, hospice, and residential facilities. So in EMS, we have found that case studies are an excellent way to put POLST into context, and so we'll share one with you today. Fire and EMS are dispatched to an emergent difficulty breathing and arrive at the patient's residence to find a husband at the front door who explains that his 62-year-old wife has a terminal cancer diagnosis and is at home on hospice. So you may find yourself asking, why did he call 911, as we might have when we were responding? But we'll give you some more information and perhaps we'll shed some light on that. So the patient then is found unresponsive with agonal respirations and a palpable carotid pulse. So in the EMS world, we would describe this patient as being in respiratory failure. The husband presents a prehospital DNR form that's valid, signed by the physician, in date, and proceeds to tell us that the patient would not want to be transported to the hospital. He confides that he's her second husband, and she also has 3 adult children, and he's not comfortable making treatment or transport decisions without them. So from the information we have available at this time, if this patient had a POLST form, what type of treatment goals do you infer she might have selected? And I would just ask if you have access to the text or the chat portion of the webinar to go ahead and submit some responses. If we had had the benefit of a POLST form, what options do you think that the patient would have selected? Anyone? Okay, so someone is suggesting no CPR or DNR, DNAR, no intubation, comfort measures. Absolutely. So unfortunately, the patient didn't have a POLST form because at the time we ran this call, we had not introduced the concept in Kansas and Missouri, which we refer to as TPOP, Transportable Physician Orders for Patient Preferences. So we were left to take the information that had been presented by the patient's husband and make decisions without any form or physician order to back us up. Now, if you watched the first overview webinar that Amy presented, you may remember that in the absence of POLST, EMS will default to the standard of care, which means full treatment, including attempted resuscitation and transport. So I would ask, do you believe that this course of treatment would honor the patient's wishes? Yeah, so probably not, at least based on our interpretation of what has been shared by the patient's husband. So without POLST, EMS is left without any tools to make this type of decision. And in this circumstance, it would not likely be addressed by an agency's protocol or policy. And truly the whole concept of patient autonomy is still just gaining traction in EMS. So anything but the standard of care, anything but full treatment and transport really requires a paradigm shift for EMS professionals. So without POLST, some might expect EMS to refer to other advanced care planning documentation, maybe the advanced directive or a living will or a DPOA healthcare. But as described in the March 13th New York Times article, the trouble with advanced directives, these documents are often not on scene with the patient when we're with them. The DPOA-H may or may not be on scene. And because these are legal documents, they are typically written in legalese and may be long and difficult to interpret in an emergency setting. And unlike physicians, EMS providers don't have the benefit of history with the patient or a long-term relationship during which we might have learned about their values and preferences. So you begin to understand that the position that we might find ourselves in as EMS providers. Knowing then how the current tools available would fail to help us solve this ethical dilemma, you now kind of begin to see what might happen to this 62-year-old female cancer patient. Her family may or may not be able to agree on her wishes. She would likely be transported for respiratory failure to the nearest emergency department facility. And after arriving there, she would likely be placed on a ventilator and admitted to the ICU. Unfortunately, if you follow this case on, that patient's wishes would likely only be honored after she slips into cardiac arrest, and then her do not resuscitate form could be applied. So you're probably wondering what did happen in this case. On scene, she was given supportive ventilation and oxygenation. Hospice was able to arrive quickly. All 3 adult children were contacted and arrived quickly. You can imagine that that added some complexity to the scene and to the situation. But fortunately, all of her family agreed that she would not want to be treated aggressively or transported. And so then we were left to contact medical control and make a case for transferring care to the hospice organization. I'm not sure if any of you have been in a position to contact medical control from a scene before and request orders like this. And you may be saying, well, this slide looks like exactly what should have happened based on our interpretation of the patient's wishes. But I can really only describe this as the most unusual alignment of stars ever to occur in my career. If any one of those family members had disagreed, we would have been required by our policy to treat and transport. If hospice had been unable to respond in a timely manner, or if medical control had said, hey, I'm not familiar with this patient, just bring her on in and we'll sort it out when you get here, then we would have been forced to treat and transport. So it seemed as though the odds were that we would be put in that position. In fact, it was so unusual that the crews went back to the station, actually had a short debrief about what it was like to leave a critically ill, dying patient at home, because all of our training is centered around rescue and resuscitation, and most EMS providers have little to no training in providing comfort care measures. We have a question about, would a CPR directive not operate as a valid order to prevent resuscitation? The key in this case is that the patient had not gone into cardiac arrest yet, so the do not attempt resuscitation doesn't apply. As long as she has a pulse and is breathing, that form only serves to tell us what we would do when we get to the next step. So without POLST, the EMS doesn't have the tools necessary to be able to make those treatment and transport decisions prior to cardiac arrest. Great. Since we have paused here, any other questions thus far? I think we had agreed we'd go ahead and take them throughout the presentation instead of waiting until the end, so feel free to send those in via chat. All right, well with that we're going to switch speakers. Katrina's going to take it from here and talk a little bit about pathways to implementation, and I'll mute my speaker.
When you look at the pathways to implementation, this toolkit includes this case study as well as other tools to assist agencies with the implementation. We'll discuss some engagement at the service level, local community level, as well as from a regional and state perspective. So the first step is to identify the organizational champions. Perhaps an implementation team is made up of field providers, educators, and administrators. Need for medical director support because you can't change protocols without it. For agencies who follow statewide protocols, it's necessary to involve that state office of EMS. The toolkit also includes links to sample protocols and a list of state EMS offices, because in some places this may already be being started from another area within government, and you may not have any idea, and so therefore you get those conflicting roles and rules and regulations. When we look at the pathways to implementation at that local level, first response agencies like police departments, fire departments, volunteer departments, police agencies may carry AEDs and respond to cardiac arrest. Long-term care facilities are hopefully engaging on their own, but transitions of care and determining when they need to dial 911 and when will access be important. Hospital EDs where patients will be taken are hopefully engaging in their own, but again, the transition of care on how to request the POLST or related orders must be coordinated. Education regarding hospital destination is important. Critical patients goes to the nearest facility. Maybe that's not the patient's preference at that time. We found that this graphic depicts the wheel of hospice care, and traditionally EMS has never been part of that. As stated in my introduction, I am new to the role as an executive director of hospice, and it's been an educational experience because learning this wheel is not something that we have in our pre-hospital education, and it's something we should have in our pre-hospital education. Again, when you look at the pathways to implementation at that regional and state level, regions in Kansas and Missouri, the Mid-America Regional Council Emergency Rescue Committee became an avenue to ensure a patient was treated the same, whether they were picked up on the Kansas City side or the Missouri side by primary or mutual aid agencies. This also allowed collaboration of several agencies, medical directors, on the development of a new comfort care protocol. This regional organization encompasses all fire and EMS agencies in a 9-county bi-state region. State Missouri Bureau of EMS, Kansas Board of EMS can ultimately support, can issue support of our or regulate regarding the POLST issues. There are other examples within other different states as to what they have. Currently in Iowa, we have a POLST form. We call it the iPost form, but we also have an out-of-hospital do not resuscitate form. So it's very important that the local care provider as well as the families realize what it is that they actually have in the event that they have a critical crisis. The barriers to implementation, lack of palliative care, comfort care protocols. Again, most of us in the world of emergency medical services are really not informed about palliative care or comfort care. This toolkit discusses some of the barriers to implementation and gives advice about how to navigate through those issues. Financial concerns is another one, and then obviously operational or system demands can be another barrier for implementation. When we look at the further up the stream on barriers of implementation, legislative concerns, there are many cases where state law regarding EMS protocol and practice impacts a state's ability to implement a POLST. At issue is the specifics of the law. You need to look and find out what does your law actually say for end-of-life care. When EMS began to honor out-of-hospital do not resuscitate forms, some states passed legislation allowing them to do so, and some even granted immunity to the EMS provider. If the language of those laws are specific to the out-of-hospital do not resuscitate forms, the legislation may not necessarily extend the same ability to honor an order or the same immunity to be granted to EMS providers for anything other than that specific out-of-hospital do not resuscitate form. The legislative process can be long and arduous, and some POLST programs find it very difficult to get those statutes updated. In our case, when you're pursuing a standard of care approach, the legislation is being avoided altogether. For some states, when you open up one part of a legislative or administrative code, it opens up the whole administrative code. So there runs that risk of other things being changed, not that specific one item that you want to have. So that has a lot of times state offices shying away from opening up any type of administrative code. High risk, low frequency type of call that requires much judgment makes this difficult for us to change because there are so many what ifs that can be asked about. What if the person has an out-of-hospital do not resuscitate for a terminal illness and crashes on this way to a chemo treatment and is a trauma code? What if, and what if? Training on duty versus limitations to training off duty, continuing education may be continually necessary. And right now, we don't have a lot of educational material out there. Training has to be included to change the expectation of EMS providers that a 911 call may not be to request for resuscitative efforts. It may be for us to come and help validate the fact that, yes, this is what that end of life looks like. Some agencies still create handwritten patient care reports. Others use electronic medical forms. Figuring out how to document what was on the POLST form is critical for quality assurance and any research that might result from the POLST paradigm implementation. For our agency, we will select POLST under the Advanced Directive tab, and we'll scan the POLST form in upon arrival at the hospital and attach it to the EMR. We will have to figure out another plan for the patient who refuses to transport, so that how do we capture that a POLST form is being attached. I'm going to turn it back over to you, Angela, for any of the questions.
Great. Thank you, Katrina. And we do have a couple of questions. So the first question is on behalf of clinics who may call 911 if a patient needs help while at a visit at the clinic. If the patient goes into cardiac arrest during the office visit and the clinicians have access to the POLST and the patient has requested do not attempt to resuscitate in Section A, the question is, what should clinics do? A person states, I know they should honor the POLST orders, however we do not have this process in place for the clinics and they're looking for recommendations. So if you're out there and working in a clinic that has some type of policy or process in place, feel free to share what you do via text. I can only echo that I agree that the clinic would need to honor the POLST orders and start working on developing the process and procedures that would allow you to do that. So same kind of scenario in EMS, where when first posed with a question of what we would do for this patient, we wanted to do the right thing for the right reason and quickly realized we didn't have anything to back us up in terms of policies or protocols or processes, and that's why we decided to go down this path of creating that. So I think there's two questions there. One is, what do you do in the short term until you have those processes in place? And the second question may be, what should that process look like? I don't know that I can answer that on behalf of your specific clinic, but I think you could create either a policy or process or protocol that would address, here's the steps we're going to take if this should happen to a patient.
And I think that is one of the massive reasons why this toolkit was designed and developed, to help all of those different sectors within that continuum of care for a patient, so that you can look at and garner some maybe tools within this toolkit on what to do at a clinical level, what to do at the emergency department level, what to do as a primary care, and look around your community to find out whether or not your community is utilizing this POLST form. Where did this POLST form come from? How did it get started? So that you all are part of that champion team.
And again, if there's anyone out there working in the clinic that has this in place, feel free to share that via text and we can share it with everyone. So the next question says, does the comfort care protocol include all levels of care or for comfort measures only? I want to make sure that I understand the question. In our situation, the comfort measures protocol or comfort care protocol would only be implemented or enacted or followed in the case of a patient who has selected comfort measures as their treatment goal on the POLST form. So if they have selected full treatment, they will receive full treatment. If they have selected some type of limited additional intervention, that's what they will receive. And only in the case where they have selected comfort measures would we enact the comfort care protocol. So I hope that answers that question. Please clarify if not. Another question, is the POLST form already being implemented in the state of Florida? I might ask Hannah, would you be able to comment on the status in the state of Florida? And maybe, I'm not sure if they want to clarify in general or if they're looking for an EMS specific answer.
Yes, so Florida is a developing POLST Paradigm program, and I know they are piloting the program in some parts of the state, but also running into some trouble, but I can definitely follow up via email with a more specific answer.
Thank you. Another clarifying question. Person says also DNR does not mean do not treat, correct? And that is absolutely correct. It's really important and part of our training with EMS professionals to understand that any choice selected on the POLST form is a level of treatment, a level of care, and we will provide care to every patient. That care will be in line with what their treatment goals are based on their selections made in Section A and Section B. So good clarification. And it looks like we have an update there, a note that maybe Florida is struggling a little bit with a legislative approach there. So certainly something that other states have experienced as well. Any other questions? I think the key is really to think about every handoff point that a patient with a POLST form might encounter. Every time they change location, every time they encounter a different care provider, and part of implementation means for EMS to understand what does that transition look like at the emergency department, what does that transition look like to a hospice provider at the home, and vice versa. If a hospital is sending a patient out via EMS back to another location, what does that transition look like, and how do we make sure that our policies are written in such a way to allow that continuum to be very seamless?
I think the other thing I would like to impress upon the audience is to go to your state office of EMS and find out what exactly do you have within the state, and find out what education is being done out there. I still find it amazing that the state of Iowa adopted their POLST form back in 2012. They still have EMS agencies that did not realize that it was there and around. I have communities that did not realize. I have communities that I'll go in and talk to, and they'll have a nice little bracelet that says DNR, and I'll ask about that to the individual, and they make the assumption just because they wear a medical alert bracelet that they put DNR on, that we as EMS will not resuscitate. They don't have a full understanding of the forms and the legality of what we need to have in policy and protocol. So I think educating also about end-of-life and end-of-life wishes is something EMS has not been in the forefront of, but needs to be in the forefront.
Looks like we have another question. Is there a way to find out how other states got past legislative and other barriers? I think that's, as Katrina mentioned, maybe one of the main goals of this toolkit, and an opportunity to have an insider view of each setting and how POLST has been implemented in each of those settings and what some of the challenges were. So for this particular toolkit for EMS, we discuss in a little bit more detail in the toolkit what some of those barriers were and how some of those states got past that. In our example that we shared with you in Kansas and Missouri, we have avoided the legislative route by implementing via a standard of care approach. So that's one of the ways. The POLST.org website is a tremendous resource in terms of there's been a lot of research and a lot of information gathered and organized in a way to allow people to access those kinds of issues. And then using your contact, either your state contact or anybody that's involved with the National POLST Paradigm Task, the national office, you can ask those kinds of questions and say, hey, here's an issue we're having in our state. Have you come across another state that's encountered that same issue, and can you provide me with a contact person to follow up and get the details? Hannah, I would ask, is there anything that you want to add to that in terms of how folks could track down that information?
Yeah, exactly. Thank you. So if you just go to POLST.org, and we have a map page, and you can click on all the states and pull up contact information for that state. So if you have state-specific questions, you can absolutely reach out to the national office, but we also encourage you to get in touch with the state program leaders.
Good, thank you. Follow-up question regarding comfort measures. The statement made, professionals get confused with comfort and comfort focus only. How will this be clear for EMS and others? That's a great question. We've made the point that every level of option in terms of treatment goals on the POLST form involves care and treatment, I think this question then makes us look at it from the other direction, and how do we provide comfort type treatments for the patient who maybe is also a full treatment. I'm not sure if that's where we're headed with that, so clarify for me if not. It is an interesting kind of paradigm shift for EMS. I think historically our industry has been a little behind in terms of things like pain management and pain control, really focused on resuscitation and treatment and transport, and has been working as an industry to get better at things like pain management and pain control. The idea is that the POLST form is specific enough to really give that healthcare provider an idea of what the patient would want in that set of circumstances. And certainly if the patient can still speak for themselves, they can provide additional clarification if necessary. So one of the examples would be part of our comfort care protocol allows us to access the comfort kit that may be at home with that patient provided by a hospice agency. So it may give us access to more tools than we would have in our own toolbox for that particular situation. So that's one of the ways we've tried to expand that understanding and knowledge of comfort measures with that protocol. Good. So more clarification about resources and state contact information at POLST.org. And if you go to the map page, you can get state-specific contact information. So if you are thinking about implementing or in the very early stages of implementing and want to know where your state is at and who the contact has been thus far, that's a great place to start. All right. Well, we thank you so much for joining us today. We hope that you find the toolkit helpful. Certainly if you have any additional questions or situations that you'd like to follow up on, you have our contact information and can also use the national office.
Thank you so much, Angela and Katrina. And I encourage everyone to sign up for the upcoming webinars. And again, any additional questions, please reach out. Take care, everyone, then. Thank you.